I am pleased to introduce Dr. Anwar Islam, the inventor of the first bone marrow biopsy needle, featuring an internal core retention device. This innovative design ensures that when the biopsy enters the hollow needle, it cannot slip out. Dr. Islam specializes in hematology and hematological oncology and serves as a clinical associate professor at the School of Medicine at the State University of New York at Buffalo. His new book, titled Extended Manual of Bone Marrow Examination, has just been published by Cambridge Scholars Publishers in the UK and is available on Amazon. Today, Dr. Islam will demonstrate and discuss the optimal techniques for performing two important clinical procedures in hematology: bone marrow aspiration and bone marrow core biopsy.
Thank you, Joe, for your kind introduction. Bone marrow examination, as you know, is crucial for the diagnosis and management of patients with various hematological and non-hematological malignant conditions. In some cases, it is the only method that can provide an accurate diagnosis. There are two ways one can examine the bone marrow. The first is the bone marrow aspiration, which involves obtaining a sample of liquid marrow from within the inner fixed confines of a bone marrow cavity. This is done using a smaller bore bone marrow aspiration needle known as the eye needle, which typically has a diameter of 15 gauge and is either 2 or 4 inches long. From the aspirated marrow, smears are usually prepared. To prepare smears from the aspirated marrow, it is important to do so as fresh as possible, ideally before the sample leaves the operating room and before sending it to the pathology department. These slides are then stained using either May-Grunwald Giemsa or Rice Giemsa stain, depending on which side of the Atlantic you are. After staining, the slides are examined under a light microscope to study the elements of hematopoiesis. This includes assessing the erythroid precursors, myeloid precursors, and megakaryocytes, as well as looking for any abnormal cells that may indicate conditions such as leukemia, lymphoma, or multiple myeloma. The second method of bone marrow examination involves obtaining a solid core or trephined biopsy specimen from the posterior ileum. This technique allows for the collection of a segment of marrow along with its bony trabeculae and marrow architecture undisturbed. It is performed using a longer and larger bore bone marrow core biopsy needle known as the J needle, which typically has a diameter of about 11 gauge and is either 4 or 6 inches long. Other sizes of needles are also available. Both bone marrow aspiration and bone marrow core biopsy play a complementary role to each other, and both the procedures are usually performed at the same time, one after the other. Under no circumstances, both bone marrow aspiration and bone marrow core biopsy using the same core biopsy needle as practiced by some, particularly by the interventional radiologist, should be encouraged. In the past, bone marrow aspiration was performed almost exclusively at the sternum. However, it is now commonly done at the right or left posterior ileum because this location is much safer. The posterior ileum also contains the largest area of bone marrow, which is close to the body surface and easily accessible. Most importantly, the larger size of this site allows for both bone marrow aspiration and core biopsy to be performed at the same time without compromising the quality of either specimen. Let me go over the actual operative procedure and demonstrate how to perform them correctly and to achieve the best possible results. I usually conduct the procedure in the operating room with soft sedation or MAC anesthesia, which is also known as monitored anesthesia care. In most centers, the procedure is typically performed using only local anesthesia. First of all, place the patient in a right or left lateral decubitus position with the knees bent forward and back comfortably flexed. Then, locate the posterior iliac crest or posterior superior iliac spine either by palpation or with ultrasound guidance. The posterior superior iliac spine lies almost exactly opposite to the anterior superior iliac spine. Now, once the posterior superior iliac spine is located, mark the area either with a thumbnail pressure or with indelible ink. Then prepare the area with alcohol, chloroprep, or iodine. Then drape the area. For draping, I usually use towels, but the drape which is provided in the kit can also be used. Then infiltrate the skin with a local anesthetic, 1 or 2% lidocaine, with a subcutaneous needle, which is about 30 gauge and 5/8 of an inch long. Now, once the skin is infiltrated, remove the subcutaneous needle and replace it with a slightly longer and larger bore hypodermic needle. Now, for obese patients, you might need a similar bore but a much longer needle, such as the spinal needle. Now, before introducing the hypodermic needle, make sure that the skin over the posterior ileum is numb. Then advance the needle and infiltrate the subcutaneous tissue, fat, and periosteum. Now, during this periosteal infiltration, it is useful to probe the area with the same needle to roughly outline the borders of the posterior ileum. This maneuver also gives you an indication as to the depth at which the bone will be met, and it also helps for the proper angulation of the needle. Now, once the posterior ileum is infiltrated, withdraw the needle and massage the area for the anesthetic to take effect. Now, let us proceed with the bone marrow aspiration using our single-use bone marrow aspiration needle. For this, we do not need any skin incision. Now, introduce the needle through the skin, pointing towards the posterior superior iliac spine. Now, once the posterior ileum is reached, it is then penetrated with gentle alternating rotary motion of the needle. Now once the needle, tip of the needle is inside the marrow cavity, unlock the stellate by twisting it anti-clockwise and then remove it with a straight pull. Then attach a 3 ml syringe and aspirate only a small amount of marrow between 0.5 to 1 ml, and then remove the syringe and put a little cap over the proximal end of the needle to prevent any spillage of marrow or blood. Then place this small amount of marrow into a small tube containing EDTA, and this marrow will be used for the preparation of bone marrow aspirated smears later. And in this way, the morphology of the cells or morphology of the hematopoietic cells are best preserved, and the smears should be made as soon as possible, preferably before the specimens are sent to the pathology department. Then remove the plastic cap and attach a 10 ml syringe to aspirate about 7 to 10 ml of marrow. Then remove the whole needle assembly and put a little gauze and keep that area under pressure to prevent any bleeding. Now place about 2 to 3 ml of this marrow into a tube containing lithium heparin. Again, the tubes has to be shaken to prevent spontaneous clotting. Now this additional marrow is taken for morphology, flow cytometry, cytogenetics, and molecular studies. Also, if any other test that might be needed. Then rest of the marrow is placed into a jar containing 10% formalin, and this will be used for the preparation of clot section. This completes the bone marrow aspiration procedures. Now let us proceed to do the bone marrow biopsy. For this time we have to make a small incision about 3 millimeter with a sharp pointed scalpel. Now I'm going to show you the actual operative procedure for obtaining a bone marrow core biopsy specimen from the posterior ileum using our single-use core retention bone marrow biopsy needle. Now hold the needle assembly with the T-bar handle in the palm of your hand and place the index finger over the shaft of the needle. The placement of the index finger over the shaft of the needle helps stabilize the needle, and it also permits adequate control and maneuver during the biopsy procedure. Now introduce the needle with the skin incision and advance it forward towards the posterior ileum. Now once the posterior ileum is reached, it is then penetrated with gentle alternating rotary motion of the needle. Penetration beyond the cortical bone with the stellate in place should be avoided because that will reduce the length of the biopsy specimen that will be obtained. Now, once the cortex is penetrated, hold the needle assembly with your left hand and remove the white plastic cap. Then unlock the stellate by twisting it anti-clockwise and then remove it with a straight pull. Then you can place the white plastic cap back again for comfort. Then advance the needle with slow, steady, and controlled clockwise and counterclockwise rotary motion. Now I find it useful to put my left hand over the anterior ilium with my middle or index finger on the top of the anterior ilium. That not only helps me to stabilize the patient and the pelvis, but it also helps me to direct and guide the needle towards the anterior superior iliac spine. Now advance the needle with slow, steady, and controlled clockwise and counterclockwise rotary motion until an adequate depth is reached, which is about 15 to 20 millimeter. Now once an adequate depth is reached, the needle is rotated on its long axis completely a couple of times with clockwise and counterclockwise rotary motion to sever all the trabecular connections at the base of the marrow core. Then withdraw the needle with a straight pull. As you have seen, we have withdrawn the needle with a straight pull. No rocking or sculling or gyratory movement or change in the direction of the tip of the needle was necessary. Furthermore, this needle technique also does not require any additional components or parts such as sleeve, hook, coil, or marrow acquisition cradle to capture the biopsy specimen as is needed by other conventional bone marrow biopsy needle. The important feature of this needle is the carefully tooled distal cutting end of the needle with a internal core retention device, which ensures that once the biopsy specimen enters into the hollow needle, it cannot slip out. Now, remove the white plastic cap and put the insertion aid to the opposite end of the needle, and then introduce the pusher and gently push it forward to remove the biopsy specimen which is contained within the lumen of the needle through the opposite side of the biopsy specimen of the needle. And here you can see a nice long core biopsy that is obtained with this needle with little or no distortion of the marrow architecture. This is the biopsy. Here you can see that the biopsy was placed on a slide, and this will be used as the preparation of touch preparation. Then place this biopsy specimen into a jar containing 10% formalin, and this slide on which the biopsy was placed will be used as a touch preparation because some of the pathologists do like to have a touch preparation. Now this biopsy will be sent to the pathology department for histological section preparation. So this completes the bone marrow biopsy procedure. Now let me demonstrate the preparation of bone marrow aspirate smears. For this, we need a glass pasteur pipette. A plastic pipette like this are usually not suitable. Now with this glass pipette, draw only a small amount of marrow from the first pull. Then place a little drop and then draw the spreader slide and then gently push it forward to make the smears. So once these slides are dried and they are placed on a slide container and sent to the pathology department. So this completes the bone marrow aspiration and bone marrow biopsy procedures. Now once the procedure is complete, a gauze dressing is applied and then the patient is advised to lie flat on his or her back for 15 to 20 minutes or maybe longer if the patient has got a low platelet count. So this concludes the entire operative procedures for bone marrow aspiration and bone marrow core biopsy using our single-use bone marrow biopsy needle. And I have also demonstrated the preparation of bone marrow aspirated smears, and I hope you will find this presentation useful for your practice. And lastly, I would like to thank Laurie and Veronica for their outstanding assistance, and Jennifer for the MAC anesthesia, and of course Joe, my friend and colleague, who has made this video possible. Finally, and again, I would like to emphasize that under no circumstances a bone marrow aspiration and a bone marrow core biopsy should be performed utilizing the same bone marrow biopsy needle, that is called one needle technique. Bone marrow aspiration and bone marrow core biopsy are two different and distinct procedures. For all practical purposes, a bone marrow aspiration should be performed first with a bone marrow aspiration needle, and then a bone marrow biopsy should be performed from a slightly different area with a bone marrow core biopsy needle. If the bone marrow aspiration is performed first using the same bone marrow biopsy needle, then most of the marrow from within the intertrabecular marrow space is removed or sucked out, leaving the biopsy specimen completely denuded or devoid of actual marrow tissue, and the biopsy specimen is usually unsatisfactory and not good for any histological evaluation.